In the discussion of caregiving in aging society, two contrasting solutions are proposed to the growing demand for care and the decline in traditional family structure. What is called the high road solution, care is a social tax, care provision lies in the state. And what is called the low road solution, care is a private matter, a family task. The aim of my presentation is to discuss in-between solutions to high road and to low road solutions, to discuss the way in which live-in home care workers give a special configuration to elderly care in Brazil and in Italy. Using an ethnographic approach and based on field work conducted in São Paulo, Brazil, and in Bologna, Italy, with caregivers and their employers. The aim is to show how the visibility gained by this duo, the elderly and care workers, redefines forms of dependence, gives new meaning to family relationships, state obligations, and domestic life. The discussion about home care workers for old people in Brazil cannot ignore domestic workers and the service they provide, even when the principal caregiver for the elderly person is a family member. Domestic workers have been constant in Brazilian households since the colonial period, a time marked by slavery. Brazil, as Lily showed us yesterday, since the colonial period, was the last country in the Western world to abolish slavery in 1888. I'm presenting here official data on care workers in Brazil, and according to the International Labour Organization, Brazil is the country with the most domestic workers. Is the profession of 15% of economic active women and the third most common profession among women. These data are data about domestic workers, and we must have in mind that is the informality prevails in this area. In 2011, for the first time in the history, an international treaty recognized that these workers have the right to fair labor conditions. In Brazil, in 2013, a constitutional amendment was approved granting domestic workers labor rights guaranteed to all employees, such as compensation in case of dismissal, unemployment insurance, extra pay for shift night work, family allowance, and etc. The amendment has been a widely discussed topic in political realm, and there was an agreement between different actors from across the political spectrum that the new law represented an advance towards a fairer society. This moral consensus among different actors is the fruit of a close relation between domestic workers and slavery. In the words of Cleusa Maria Oliveira, president of the National Federation of Domestic Workers, the origin of domestic work in Brazil is slavery, and the new law is not only about equal rights, but also social inclusion and historical reparation. The French newspaper Le Monde published an article on the subject entitled "The Second Abolition of Slavery in Brazil." Criticizing the legislation is ethically intolerable. The difficulties which could result from the implementation of the law were expressed regarding possible unemployment due to the increase in the cost of labor, which could lead to a reduction in the offer of employment. The difficulties which families would face appeared in the form of specific case report always preceded by the statement that the law is a social and political advance. The Brazilian case showed that public policy promoted family care even when it was an unintended side effect. Two types of solution are proposed to reduce the load care represents for the family. The state should offer financial resources to relative who care for their elderly, or the state should guarantee that the salary paid to the caregiver can be discounted from the income. I will jump to Italy because of the time. In some European countries, particularly Italy and Spain, a peculiar relationship has been established between the family and the state when the care for the elderly is at stake. This relationship has already been nicknamed the Mediterranean system of welfare, or welfare leggero, or light welfare, since families use low-cost foreign labor, in particular illegal immigrants. The Badanti is an immigrant woman, is a new caregiver figure in Italy, and she is employed as a domestic worker with the task of helping and taking care of old people with whom she generally resides. The Badanti labor market underwent a transformation in the last decades involving the replacement of caregivers from Latin America, Africa, and Asia by Eastern European immigrants. I am quoting an Italian sociologist who had just hired an immigrant from the Republic of Moldavia to take care of her elderly father. She said, Eastern European immigrants have much higher education levels, greater experience in taking care of the elderly people, and above all because they were older. They do not need to look after small children, they do not look for boyfriends, they do not look to dance, do not go out to dances. In short, they are more available for care work. Our research show that the Badanti from the countries which took part of the former Soviet Union have higher education than Latin Americans, Philippines, and African workers. It's normally the way they say that Latin Americans come mostly from Peru and Ecuador in Italy are good for kids, and the Africans to clean and other hard jobs. And accusatory and division are present also among immigrants from Latin America. In the words of Maria, a Peruvian immigrant care worker in Italy, she said, Eastern Europeans are cold, calculating, and accept work for any wage, because they really, what they really want is to marry the elderly person they take care of, in order to legalize their situation and improve their life. Asian, you never know what they are thinking about, as they are always smiling and no one knows why. African, a very background, come from a society in which there is neither cleanness nor education. It's only us who knows what care and respect for the elderly really are, as we learn how to take care of the elderly by looking at our own family. It's impressive how the convention linked to ethnicity, nationality, and gender give a special dynamic to this market. Culture is seen as essentiality and as a static identity subtracted from the historicity of social relation. Care become a national vocation naturalized in the immigrant women. The fact that policy aimed at the elder are relatively underdeveloped is one of the reasons most strongly stated by researchers to explain the emergence of the Badanti. The possibility of providing private care work at home to this gray zone of illegal work guarantees access to this type of service to large part of the population, transforming Italy into the country of the badanti, as it was named by Vietti, and transforming European domestic unit into a sort of exotic microcosm. The private market of elderly care is apparently a victorious strategy for various players involved in it: the elderly and their families, the immigrant, and those responsible for public policy. For the elderly and their families, it's a much more economic resource from the financial point of view than homes for the elderly, which are expensive and seen as being a type of dumping ground for the elderly. For the immigrant worker, it signified the possibility of gaining a much higher monthly wage in comparison with their country of origin, and it is also a form of protection in contexts in which they are illegal. The caregivers I interviewed in Bologna were all very satisfied with the relationship they established with the elderly they care for and their families. Nevertheless, they all had stories to tell about adult children who were very, very slow to come to their parents' house on Sundays, so that the caregivers never knew when her day off would start or end. And also reported were cases of children that brought to the parents' house all the dirty laundry to be washed by the badanti, and also of discount or delay in the agreed monthly or weekly payment. For the state, it result in a considerable reduction in care demands. From the structural point of view, the flow of workers to provide care to the elderly in rich countries is seen as an effect of the growing division of health and labor in a globalized world. This movement, accompanied by the detention and the deportation system, ends up establishing labor system which present a continuity with slaveocrat practice. For many authors, that is not a practice that persists, but far from being archaic, this labor regime are constitutive of capitalist development, which seeks to limit the mobility of workers in a continuous process of replacement of people willing to accept badly paid and low status work. In this sense, the way that Giorgio Agamben draws on the expression homo sacer is used to describe illegal immigrants. In contrast with the structural analysis, other authors have sought to show that the situation is much more ambiguous and emphasize the way in which the experience of caregiver is lived in different contexts and how the power of negotiation is even present in the weakest spring of the relation put into action. The frontiers between traffic, prostitution, and the work of migrants are frequently blurred or gain unusual meanings. A project in Germany proposed to train prostitutes as caregivers for the elderly, and this project was presented as being very logical due to the lack of caregiver in old persons' homes and to the fact that prostitutes make excellent carers as they have good people skills, aren't easily disgusted, and have zero fear of physical contact. Far from denying the reality of the dramatic history of this woman, talking of slaveocrat practices are very complicated and problematic. First, because it denies actor agency capacity of caregivers. Second, it ignores the fact that domestic care is an active element in the production of the Brazilian and Italian respectable family, the ones who keep the elderly in their own houses in opposition to illegal immigrant caregivers or domestic workers that abandon their family, their small children, or elderly relatives in search of better living conditions in other countries. Third, it prevents the imagination of innovative and creative forms of home for dependent elderly and prevent the recognition that dependency is not a synonym of lack of interest in an active social life, which go behind the limits of the family. To end, what I want to show is how there is a process of reprivatizing old age. Public policies are active in creating family and its obligations. Even when cares enter the agenda of political discussion, or even when policies are more tolerant with illegal immigrants, as it is when they are caregiver, as it happens in Italy, dependence in old age is transformed into a family responsibility. Thank you.
So, first of all, I would like to thank everybody here for this very important session. And I think that the organizers, they did a wonderful work, and it's a very important subject that we are discussing here today and yesterday. And I'm very happy to be with you. I'm going to tell you about our work that we have been developing in Brazil, okay? And this first image is related to a work finished by two young people, by two adolescents in one of our groups that I'm going to tell you about it. So the work is that I'm going to tell you about is called Adolescents in Primary Health Care in São Paulo, Brazil, Challenges and Tools to Achieve Comprehensive Care. I'm going to tell you then about, in this presentation, about a practical attempt to translate adolescence as a marker of social difference into a practical setting of techniques and tools that we are experimenting with the program of adolescent care of the Professor Samuel B. Pessoa, a teaching health unit of the Medical School of the University of São Paulo in Brazil. The aspects to be described and discussed here are, of course, just a few highlights from the complex day-to-day work of a community-based health service and of the combined efforts of an interdisciplinary team committed to research and on new technologies of delivering accessible, acceptable, and effective primary health care in Brazil. The main goal of our work and of this presentation is to point out that healthcare, especially in primary healthcare settings, acquires diverse meanings and senses for different population groups, and that appropriate tools can and will be created to respond to their particular needs. So, first of all, the need of developing a specific healthcare program for adolescents arises, on the one hand, from the acknowledgement that this group constitutes a socially differentiated group with some quite particular healthcare needs, particular enough to challenge the more conventional ways of organizing and delivering healthcare. On the other hand, it must be recognized that Brazilian adolescents seek healthcare services daily at primary healthcare services, including both basic healthcare centers and family health units. Adolescents are, from an epidemiological point of view, a population of relevance for health promotion and disease prevention, and primary health care can contribute to enhance health and life opportunities for adolescents. So, to discuss primary health care for adolescents, we must first describe primary care definition and its attributes. Primary care can be understood as a technology from a broad perspective that includes both material and not material instruments and actions to promote health, prevent diseases, and or recover and rehabilitate the health of individuals, families, and communities. Primary healthcare is a low complexity technology with regard to its material tools in terms of equipment, medicines, or physical producers it involves. However, it can be considered a highly complex technology when one takes into account the non-material aspects that are crucial for primary health care, like communication skills, the ability to understand real health care needs, the psychosocial dimensions of healthcare and disease processes, and the management of effective, sensitive, and appropriate daily health care in a longitudinal way. I'm sorry. In a word, in only one word, we could say that a good quality primary health care demands care in a comprehensive sense. We believe that to build adolescent health care, it's essential to have a youth-friendly primary health care, concerned about the adolescent's social reality, as well as related to their quotidian life and to their territory in its very concrete relation with the way they experience health disease process and the way they seek health care. So for us, comprehensive care is somewhat difficult to define in a few words, but we can try to do that using 4 axes that can help us to understand it more synthetically. Okay? So the first axe would be to describe the needs, the health needs. That would be a comprehensive care requires the capacity to identify, understand, embrace, and respond to people's real health needs, not strictly to the active demand for disease treatment or prevention, but also concerning well-being and quality of life more extensively. Our care purposes would be to work with demands making integration between actions for the promotion of health, the prevention of diseases or harms, the treatment of diseases and suffering, and the recovering of health, physical rehabilitation, and social reinsertion. We also need articulation of effective, to do effective comprehensive care. It's only achievable if we use interdisciplinary knowledge, multi-professional teams, and intersectional actions. We also need to develop interactions. It's dependent on attentive and respectful interactions between health professionals and the persons and communities that they deal with, based in an authentic openness to otherness. Okay? So we think that specifically to build comprehensive care for adolescents at primary health care, it's a challenge due to conflicts between some of the group characteristics and the way services are normally organized. These characteristics are mostly related to the social cultural aspects that shape their process of growth and development, namely how they experience their changing bodies and minds in the context of new roles that they are culturally expected to play with their peers, their families, their communities, and in society as a whole. These are contradictory feelings and reactions to those rapid and meaningful changes. Sometimes adolescents live this experience with contradiction between desire and fear of the new discoveries and challenges that they bring them. The services organization should therefore take into account that adolescents and young adults make up a specific but not homogeneous group. Okay? And they should try to find ways to guarantee their access to primary health care and to make sure that their needs are met. Along with adolescents and youth as a marker of that difference, program managers and practitioners must simultaneously consider other social identities such as social class, gender, and race. Thus, it is complex to embrace and respond to the needs of adolescents. And the first step would be to address this challenge, acknowledging this situation. Giving them these brief outlines, I would like to share with you some experience that we have been doing at Professor Samuel Pessoa Health Center. First, it's necessary to explain to you all that it's a service that delivers health care and is also a teaching and researching unit. The service provides comprehensive primary care for a neighborhood of more or less 50,000 people, inhabitants, with specific emphasis on delivering care to programmatic profiles like children's health, adolescents, women's health, men's health, elderly, oral and mental health. We can see here, I don't know if it's a little bit small, but that's the map of our region. And also, besides being a big region, we are also a not continuous one. Okay, Centro de Saúde Escola is in the top part, close to USP, and we also have this other part here below. And so what we could say is that we have a not heterogeneous, a not homogeneous socioeconomical environment. So people are very different from their contexts. Some people like medium class and some very poor housing together. And also people with high education levels because of University of São Paulo, and sometimes illiterate people and also people that should be in school that are not. Okay, we can see here also a age pyramid, and the groups of adolescents. I think it's also small, but adolescents, if we look there from 10, the third from behind, from low to top, we can see in these two sections that adolescents would be more or less 6,000 people for us at this moment. So it's not like, if we look, it's not a pyramid of a developing country. It's already changing, so we have all these transformations, but still it's a very large population. Okay. Our unit then has developed a program to treat adolescents and to deal with adolescents' care. It started in '89, always driven by an interdisciplinary group. Okay, we are going to call it PASA. It's the nickname in Portuguese. Okay, so this program for adolescent healthcare. Today, it's a team that's composed by 3 nurses and myself as a medical doctor and coordinator of the group. We also try to always have interaction with other sectors and advice from former members. Here we have José Ricardo and Gabriela there as well. Okay, and we have always been looking for our main purposes, which are to promote adolescents' autonomy and well-being and contribute to their citizenship. And also we want to achieve some specific goals that are reduction of vulnerability to STI AIDS, avoiding unwanted pregnancy, drug abuse and violence. So our program, we have some activities and technologies, and we at our health center, we focus very much in working in developing technologies and trying also to discuss this with other people. So we have a nurse appointment, medical consultations, health education groups for adolescents and parents. We also have a life and healthcare self-reported questionnaire that is circulating to you, and after using this questionnaire we do some dialogue with the adolescent and the health team. We have some activities in schools and in communities, partnerships also with other services, sectors, networking and forums. And we also try to have always team meetings using both training, opportunities to training, and also to engage people in the democratic and participatory management of the program. So now, first of all, this questionnaire that you received, it's for us very important, you know, because it has the goal to facilitate adolescents' participation as subjects of their own care. So I think that's also trying to make a dialogue with the other talks that we heard today and yesterday. It's also a way to try to achieve care and to see that our subjects are really part of it. The idea is to have a tool to dialogue between adolescents and health team. It was developed in 2005, then it was evaluated in 2009, and then we have a new version, that's this one that is circulating for you in 2010. If we look, and I'm sure that you can see that in your hands, all these issues here, the form informs us about it. So we can know more about how young people think about how it's going with their health and illness, body and care, school experiences, use of free time, family and household experiences, dependency and autonomy, relationships of affection and sexuality, experience with drugs and violence, and dreams and plans for the future. And also in our evaluation, we learned that it was a very effective instrument. So that was also an evaluation of a non-material instrument, also relating with some of what we heard today. And we use the narratives, the stories of the young people. We can also learn a lot from one individual and also from the group, and know so how the adolescents in our neighborhood are thinking of themselves. Okay. So here I have some answers to show you in some of these questions that I select. In this, for instance, how is your health? The person marked good, and because I don't feel that's anything wrong with me. And always when we see one of these answers, we have also to discuss that with the adolescent. And it's also important not only to read the words, but also something what is behind the words, you know? Then, for instance, of course, when you feel well, that's already good. But sometimes you have to do other things to promote health. Then we have to discuss that with the adolescent. What do you think of your body? I have nothing against my body. I think I'm a normal person. Huh? But when you look, this was a boy, a young boy that was a little bit out of weight. And he had he didn't have a very good image of himself. We could see that also from other parts of the records. So you always have to see this file in context, you see. Another thing here, do people in your house help you or disturb you? The people with whom I live only think of my well-being, and for this reason they help me. And this is a very important question for us, because sometimes they say, oh, they only disturb me because of this and this, and then that's a chance for us to achieve what we are trying to do with this young person, you know. How do you see drugs in the day-to-day life of adolescents, including alcohol and smoking? I have nothing against those who use it, but I wouldn't recommend it. Mm-hmm. So this here, we must see and have, you know, the second thought. And it was a boy that was already having abuse problems, you know. So you have to go a little bit further than only the words with the questionnaire. An episode that marked your life, the death of my first boyfriend. And then I was remembering very much this part here yesterday by the lecture of Claire, because it's something that really marks people's lives. And we see that very often, these kind of things. So now I'm going to pass to a second activity that I think is also very important. That's a health education activity that we do at the community level. So we always try to do it, especially with schools, because we think that that's very important, because it potentializes our interaction with adolescents, with health professionals, and also with teachers. And also it contributes to the acknowledgement of what adolescents need. For instance, sometimes when we go in the school, after that we know better what adolescents need also back in the practice, okay? And also we think that schools are part of our territory. And when we go to the schools, we are not only expecting people to come to us, but also trying to achieve our work and our goals in the community. The school is their place, their environment. So that's a sentence of one of the people that compose our team, and shows that it's also important for the other people of the group. So we want to learn about adolescent health needs in the territory and to focus on relevant issues for this population group. So here I have some pictures of one activity that we have done in 2012 about body changes, adolescents, dating. We always use things like Valentine's Day for use this theme to make an interaction, STI, AIDS, and unwanted pregnancy. And then we had it was a kind of a market of health and education this day here. And even with showing tools and showing how to prevent, also with oral mouth education, this part here, it's about kissing and so on, and the first discoveries in adolescence. Then here they should construct two bodies and also two characters, two individuals, trying to think of names, ages, what they liked, what they didn't like, if they studied, if they worked. And then after that, these two characters would maybe have an encounter. And that's what was the encounter part, and we make a kind of role playing, and so two of the adolescents assume these characters, and the others can stop and say, no, I think that's not this way, they should negotiate, for instance, condom in another way, this kind of things. And you can see, I think the pictures are also very important, because we can see that they are very happy. They are really liking what they are doing. So, and then a third experience and last, okay, just to discuss with you, is a health education group that we like to do at our health center. That's also possible to develop groups and to make health education inside of the primary health care practice. So this group is called Dreams and Plans of and for Adolescents for the New Year. We have already done it twice, so in 2012 for 2013 and last year for this year. The goals are to learn about health and life needs of adolescents, to contribute to their plans, and to try to really achieve their dreams, to discuss possible health risks that might interfere in the accomplishment of these dreams, and to learn about also what their parents expect, and how we can help parents to not only transfer dreams to their children, but really to support their children's dreams in a more comprehensive way also. So the methodology of this group is that adolescents make a resolution list, like this list that we always make on the beginning of the year. Then after, this is very private, they don't have to tell us. After that, they only choose one dream that we should discuss everybody together, and then we think everybody together how to avoid obstacles to this accomplishment, and trying, of course, to push to some of our more objective purposes as well. And after that, they make a collective wish card from them to them. That would be so from the adolescents to themselves in Butantan. For the parents, we also make a discussion of their expectations for the adolescents and how they could support in the accomplishment of their dreams. And then they design also a wish card for the adolescents. And after that, we made a presentation of these products and end of year celebration. So as a result, you can see that we learn a lot with adolescents and parents' needs through their own participation. So it's a kind of, also of course we are using many knowledge, but also from their own participation they are telling us what they need. And we also deliver to them the resources to promote their health and to prevent their diseases. And also contribute to how they can organize their life projects and try to achieve their dreams. It's also a response to individual demands, but also trying to always put it in a collective context. And after that, we use this exhibition of these cards in the waiting room of the unit. So it's always something that more and more people can see and can discuss and comment. And as we are thinking, of course, it's only it's very experimental. We only have done it 2 times, but it seems to be reproducible. Okay. So here are the pictures. That's the first year that we have done. On the beginning, they are writing this intentions list, so you can see a more introspective moment. And then they are here already organizing this collective card. And we were together here with them, with all the room, with these things from Christmas and music, New Year's Eve, these kind of things. And here they are putting together the card. And that's the card exhibit in the waiting room. So I don't know if everybody can see, but the title of the card that they select on the first time was De Nós para Nós, from us to us. So I think that's really very expressive. And also you can see very different drawings from the youngest ones, things like, balloons, and from other ones they want to make a trip, they want to learn something, and interesting ideas that we can discuss. I'm sorry. I'm almost finishing. And here's the second year, also everything that we have done together is more or less the same methodology, but this time we also put the parents, and they made this very beautiful card for their children and also with their wishes, and then they had this common celebration. This is the card being ready, and this is everybody, including the team. They liked very much and wanted to be together in the picture. And then for now, I just wanted to point some challenges for you that I think is important. That we have been thinking that it's a big challenge to work with adolescents, but we have so far already some experience doing that and some evaluation of what we have achieved and also what we still have to learn. And one of the most difficult parts is to deal when they have very extreme conditions of vulnerability. So sometimes, as I mentioned, we have this very heterogeneous situation, but some of the adolescents have very difficult lives in terms of problems towards their human rights and so on. So that's one of the difficult parts that we have to still learn how to face it, because it's really hard then to search with them their happiness projects. That is always what is driving us in our work. A second challenge is that adolescents care requires always, as I mentioned, networking and constructing of partnerships. Because, for instance, we have to deal with schools to do what we showed you about schools. We have to go in community, we have to work together with forums, and that's not easy. It would be easy, maybe only one sector trying to dictate to the other sector what to do. But if we really want to do it together, we know that's a big effort to achieve. And that requires constant work. Also, another thing that I would say that's a big challenge is that we are facing now a context of very few human resources. And it's very difficult to tell people in my work, okay, and it's a place that people are committed to public health and everything that we have been discussing today, but it's very difficult to say that we have to work with a population that is healthy. Adolescents are healthy, and we have to work with them in order that they can remain healthy and that we can help to promote their health and their citizenship. So we have to be always remembering, the principles that guide us, including comprehensiveness. So I think that's very related to what Sophia was talking today in the morning. And also, we have to be trying all the time to construct and to develop some non-material tools to improve the dialogue between adolescents and the team and to improve our interaction. And that's very important in order to make adolescents take really ownership of their primary care practice as their place, and that they really feel that they can not only be there and be taken care of, but also make part of this care. I think that's it. I want to thank you, and I'm sorry for taking time.
So I have only 5 minutes. I will try. But thank you so much for the invitation. José Ricardo, João Bill, it's an honor to be here again. Estou me sentindo de novo em casa. Obrigada.
Always welcome, Laura.
It's great to see you, to see how this international partnership has been growing. So thank you as well to Lily Schwartz, José Ricardo, João for all these. And it's also a great honor to discuss Gita de Beer's paper. Foi presente, realmente. The work is amazing. And it was a pleasure reading the material and thinking about it. And congratulations on this wonderful international seminar. I've been learning a lot in the last 2 days. Can you hear me? Yeah? Okay. First of all, Gita, I would like to ask you about your field work. Can you tell us more? Can you explain under which circumstances you did it? It sounds really amazing to me. It would be great if you shared a little bit more with us. While I was reading your material, I thought about many questions. It's very, very interesting how the process of globalization and aging are mutually connected. The way you analyze and you understand the inequality is not only interesting, but also courageous. I do think it. And the relationship between Elvira and Vera, both domestic workers in Brazil, but both poor, they are both poor, shed light on a very complex situation about informal and cultural jobs, gender, race, sexuality, ethnicity, nation, domestic workers, caregivers, labor rights, and human rights. Can we say that Elvira exploited Vera? You said, quotation, criticizing the legislation for domestic workers, a conhecida PEC das domésticas, is ethically intolerable. Can you say more on this? For whom is this legislation? It was in my mind all the time. For whom? Reading your material and listening to you now, I realize that this is a very complex situation, because although ethical, is it fair for Vera, for instance? What's going to happen to people like her? How can we face this problem? My point is, sometimes ethical legislation is a kind of quicksand. Could I say it? Like areia movediça? That on a daily basis, life pulls us down. Or am I wrong? Can I think in this way? And it only needs time and corrections, which is your position about it. The other point is about violence and vulnerability. I think this is a question for you too, Mariana. I'm not supposed to ask a question, but if you can, talking. Because I was thinking about this point while I was listening to you. In all material I have seen about elderly people, violence is always present. You don't talk about it directly, but I assume that it's not only important, but also a background of your research. In my vision, elderly people and violence have a kind of metonymic relation. Again, am I wrong? But if they are vulnerable, and this word I do think is crucial here, they are not always victims. Can you talk about this difference? I mean, being vulnerable doesn't mean being victim. Because at least in Europe, the caregiver can be vulnerable and even more victimized than elderly. Then the elderly they look after. So what role does the idea of vulnerability play in the global market? Can you talk about it? Can you link this idea with race and ethnicity and sexuality? Because I do think that is there, but if you can explain more, it would be great. And as I read, it makes it, I mean, nation, ethnicity, and age makes a big difference in Italy. They prefer grandmothers from Eastern Europe instead of Latin American or Philippine immigrants. You said that, quotation, care competence becomes a national vocation naturalized in the immigrant women. And in Brazil, is there someone who has naturalized the vocation for being caregiver? The last question is the skill for dealing with suffering also a gender naturalized vocation? Or should I say the social markers of difference in care essentialize the difference more than in other fields we have been working? And Mariana, just a small question. Race is important in your work because I saw the pictures. There are people from different colors, but and the idea is in your work, but I couldn't see the way this is important or the role it's playing there. So I've stated only questions because I want to learn more, And this is a great opportunity, I think, for us, listening you too. And once again, I want to thank you for the invitation for this opportunity. Thank you.
Thank you so much, both of you, for your papers and for bringing these sort of very different perspectives on how age comes into relations of care and caregiving in really different contexts related to home, labor, and the clinic. So I'm going to be responding specifically to Mariana's paper and, like Jose Ricardo mentioned, to the kind of work that's being done in this clinic where I was fortunate to spend a couple of months doing research for my undergraduate thesis. So to start, I guess I just wanted to flag how interesting a sort of site this is for my research and for thinking about visions of care in particular, because it's a clinic that is so explicitly oriented around kind of the imagination and values that go into creating a distinct way of thinking about care and then implementing that and sort of experimenting with it in time and in practice, and PASA being, I think, one really good example of that. I know that as a sort of young medical anthropology student trained to identify reductionism in biomedicine anywhere I could find it, it was interesting to see a group of doctors who were talking, for example, about medicalization all the time and how to have non-medicalizing health practices, or a staff meeting where everyone was talking about how to humanize care. So this is something that's really explicitly on the agenda in this context, which I think makes it a really, really fascinating setting to think about. I also just wanted to flag something that you raised briefly, and maybe you can speak to a little bit more, which is this idea of citizenship in care, in health, and with the adolescent program in particular. I think to a certain extent that's just something that comes up a lot more in popular discourse in Brazil than it does maybe in the US, but I think especially in relation to adolescent healthcare, it's sort of something that raises a lot of questions about times of socialization and subject formation and sort of citizens in the making, I guess. So I'm curious, especially given that this is a population that doesn't require medical care in the way that we often think about it, I guess, like you say, it's a generally healthy group, how those sort of like other forms of the work of care, how that takes on maybe a political valence, or how you see that relationship between healthcare and politics. I know that seems you had it as one of the main purposes of the program, so maybe if you could speak to that a little bit more. Mm-hmm. And I guess a final thing I'll comment on that Laura also brought up a little bit, and that was in the end challenges section, but that I think is worth talking about in relation to our broader conversation here, was this question of sort of vulnerability and how to deal with sort of the outside world, what is external to the clinic and maybe outside of the traditional bounds of medicine per se, and how that comes into the work that you're doing in the clinic. And maybe, I guess thinking back to yesterday, thinking about like, how do we know what care is when medical care isn't really able to solve certain problems around poverty or violence or other situations of vulnerability? How does that change the way that you think about care or caregiving in relation to that population?
Thank you.
I have two questions. One of them is Professor Gita. When you talked about the differences in terms of nation and race and ethnicity, and I was thinking not only in terms of efficiency, but also it seems like there's almost an emotional cartography built in terms of caregiving. Like, for example, when someone said, people from this specific country, they are colder, they are more indifferent, and etc. And I would like to hear a little bit more if you identify that not only in terms of nation, as Laura said, but also in terms of region in Brazil. I personally experienced a lot of that in São Paulo. Usually when I meet people from the north, they talk about bringing nannies to take care of their children from the northern region because they're more affectionate and things like that. So and Mariana, I was thinking, I just read the questionnaire, and I thought it was very clever how you don't mention openly the gender identity or sexual orientation issue, Maybe that's a little scary for adolescents, but at the same time, I was thinking about Chris Breyer was here to talk about LGBT health and human rights, and he was talking about how LGBT adolescents are more vulnerable because of discrimination and things like that, to family abandonment, substance abuse, and etc. And I'd like to know if you have experienced that, these LGBT issues in the center. So that's it. Thank you.
Thank you so much for the two lectures we have now. I have different questions for both of you that I like very much. Given, maybe you could talk a little about, because I was thinking, I love the way you compare the adoptee and the person that take care of this kind of, that have this, offer this kind of service in Brazil. I'm a person that likes to think about names. So I would like to understand what is a badante, and normally in Brazil, we have like a very ambiguous term, because sometimes they are domestics, special domestics. So is there a difference in names? And the second thing, public and private spheres that you know much better than I, but maybe you could develop this, because one of the things that they inherit from the slave system is this very complicated use of private and public sphere. Domestic institution in Brazil is like a tradition. We call it traditional, but we have just 500 years, so everything becomes a tradition very easily. But even so, is this a kind of continuation? So how you do it, there is a difference between the way we deal with this kind of profession and in Europe, how they deal. Because I know that we have a lot of laws, and then we are talking about hours of services, but we also know that everybody is trying to negotiate with this and trying to have them all the time at home. And the third question is about colors, because the bandante that you showed us, they are white, and the image that you showed us of, what's the name in Portuguese? Das curadoras, what's the name in English?
Caregivers.
Yes. You saw the black one. But as far as I know, with the Brazilian crisis, and please correct me, you had a lot of white cuidadoras. And even people, continuing the question of the sentimental and symbolic geography, some of the elders prefer, they're not going to say it because it's not politically correct, but they would prefer white comparing to black. And if you think about region, they would prefer people coming from the south, because we had a very big German, as one said, knows immigration compared to the north. So just question, you know better. So just to let something that I wanted to hear you. And Mariana, I like very much your presentation. I was trying to think about your questions here that are very keen and smart. But I noted, and please correct me, that you have in some places open questions, and in others you have very closed questions. For example, thinking about colors, as we said, that is a very complicated question in Brazil, because people can negotiate with color. You don't have an open one, for example. I think it would be very interesting to include one if you do not view yourself in one of those categories, which category you would use. That would be good. Here, also because I think people will give you new names, new colors, and new places. Also, I think a good question it would be about hair, because in Brazil, color, race, and hair are very much connected and tells a lot, So, and then, even if you are going to use those kind of categories, are you using brown or pardo? Pardo. Are you using moreno also or not?
No, we are using the categories from IBGE.
Okay. And are you using are you comparing responses or just self-responses?
Actually, after the adolescent fills the questionnaire, and after that we always discuss the questionnaire with the adolescent himself, you know. So it's a very direct use. And after that, some of the questionnaires sometimes we use for some evaluations, but that's not a monitoring process.
I know
But we do it from
Just a last question, because depending in Brazil, depending on the person that is going to ask the question, depending on the color of the person that asks the question, the answer can be different. So
That's self-filled.
Yeah.
We are not in the room when we do that.
Okay.
You know?
Great. Thank you so much.
But then I can answer that.
Agora era melhor responder.
Quem sabe eles respondem.
Muito bem.
You should respond a little bit, because if not, we will just be overwhelmed with too many
Yeah,
questions.
it's really impossible.
So, can I thank you very much. You made great questions, all great questions here. About my field work, I began the research in 2011. I was invited to offer a course on gender and aging in a program. GEMA's program is a program that has the financial support of the European community, Erasmus Mundi, and is about gender studies, women and gender studies. And at the same time as I was doing the course, I had to do to have a research project. And I decided, because of the language facility, to study immigration from Latin America to Italy to work with the elderly, because I'm working with questions related to aging and old age for a long time, so I decided the course was gender and aging. So I begin like that, and I begin the research. Someone told me about a church in the center of Polonia. They have a mass every Sunday with Latin American people. So I went there, and the nun that was there helped me to she tell me who were Latin American caregivers, and she asked them to give me interview and all that. And to the side of the employers, I used the university where I was. And it was in the university that I discovered the change in this market. And it was really very difficult to do the research with women coming from the Eastern Europe. I wanted them, they are in the illegal situation, and the majority were from Moldavia and Ukraine, because Moldavia and Ukraine are not in the European community, not yet. And so it was very difficult because of the language. And I have just one of my interviews that spoke English. She was in Moldavia, an historian professor historian professor at the university, and she won 40 euros per month. And so she decided to come to. So with her, I could speak in English. But the rest, I have a student from Poland, so it's a strange field that spoke Russian very well, and so she did with me the interview. So it was very complicated because I asked her the question in English, she translated it to Russian, and the majority of them, they speak Russian very well in Moldavia and in Ukraine. So that was the work, the best. But it was my colleagues at the university that told me about this change in the market, no? And they really prefer. On Elvira e Vera, I didn't explain that was in the paper, but not in my presentation because of the time, no? So Elvira, she is a domestic worker, and she spends all the day from Monday to Friday. She works in a house, and in the weekend she goes to her house, and she has 2 kids, and there is a neighbor that take care that took care of their kid when they were boys, but now they are grown up. But the neighbor comes and makes the clinic and has a little salary to do that. So what is the problem? She doesn't define herself as being a domestic worker. She tells, I am helping my neighbor, but she wins that. She has a work, but she has small kids, so the way she arranged to have a salary, to have a sort of, not salary, but she helped women that work in the city to taking care of the kids or cleaning the house. But I think with the new law, it will be really a problem how she define herself. I think that when they have good relation, it's okay. But if the relation are not so good, she will ask for the justice system to say, I work for her, and can be if there is a fight between them, it will be complicated. But till now, it's okay. So it's a very complicated question. She's exploring the other one. I don't know. They don't feel like that. So exploration is something that it depends how the people feel it. Let me. There is the profession of caregiver, but there is not a law saying what does. And it is a discussion in the parliament. It's a very complicated discussion because what someone has to learn to be a caregiver. The nurses or the social assistant, who will give course, what they have to learn to be that. So she's not, what is that? To have rights. So I'm not discussing here caregivers as a profession, but I am discussing domestic worker because at this moment the law is on domestic worker and not on caregiver, on caregivers. No? Violence and vulnerability. I think that's a very interesting question, and what's important to have in mind that when we speak on elderly, it's a very heterogeneous population, no? And in the beginning, in the first studies about elderly and old age, the idea is that they are so similar, the situation, the sort, the idea of role-less role and all that, that to be elderly is most important to other kinds of difference that could exist. But nowadays, the difference is recognized, and in Brazil, you consider elderly 60 years or over, no? So there is people that have all the functional autonomy, and there are people without this autonomy. In Italy, it's very different because really the badanti is the way they translate to caretaker, no? But it's this kind of immigrant woman that goes to take care. She makes, in the majority of cases, she lives in the house of the elderly. But who contracts are the children, not the son, the daughters, majority of the case, the daughters that contract them, but they don't live in the same house as their parents, no? And it's very different, the situation of elder people in Italy and in Brazil, because in Brazil people, elderly, if they are not so elderly, they stay always at home, and the domestic worker is there, no? In Italy, the badanti, in the majority of the case, she works to elderly that are very dependent, no? So there is a big difference in this situation. The thing on the home for elderly, no? I think that's a very important thing, because in Italy, as in Brazil, there is a very hostility against all the sort of houses that congregate elderly people. And I think that's a great problem, it's very important to change the mind, but to change the mind, you must change also the institutions that take care, no? And I hope, and I think about my independence, the moment I will be independent, I would like very much to have homes for elderly, not to be dependent on the family and all that. And I think that all my generation has the same idea. They don't want to be dependent of the children and all that. But gerontologists and geriatrics in Brazil, they love to say that elderly, all along the history, in all situations, they want to be cared by the children, and not. I think that's not true, and so I think that to think on old age, we have to have in mind that there is a dynamic. And things change very quickly, you know. How it changed to children, no, because when I was a child, to go to a crash, it was something terrible, no. The mothers that don't keep well the kids, we call them denaturalized mothers that send their children to the school. In one generation, to my kids, when they are 2 years old, they must go to, because it's good for them, for the sociability. And we don't call crash, we call maternal. We gave other names, but it was a big change in a very small time. So I would like to contribute personally to this change in relation with this idea. I think that the United States model in this sense is much more adequate to my generation when they will be, to the needs of my generation when they'll be dependent, no? I think that very interesting this idea of emotional cartography and the way there is the things I quoted that is not I think like that. I'm quoting what they say, and there is a competition in this market, you know. But anyway, I think it's a very interesting sort of immigration, no? Because when you think about immigration, we think on men, young men, and with very low level of education. And that is an immigration of women in the 50s, in the 60s, as you can see in this the picture I show, and with high level of education. So it's so when I discovered this immigration from Moldavia and Ukraine, I was very interested because it's another kind, and it's very different from Philippines, because the woman told me why they are coming, why they are working here, to help my kids, to my kids study, but they have grandchildren and all that. So I think that is a way of giving dignity to the immigration and the work they do, saying that they are doing that just to help their kids, the studies, to go to university and all that. So it's the name of Badante. Badante is the caretaker, but they use that to the immigration, and it's a discussion because they want to change his name. It's I don't want to, but it's how to call them. It's a problem. What is the political correct way of calling this? But Badante is the way they use, and I think that the public and the private that you ask, it's a very interesting question. But what I think the elderly don't live with this with their kids, no? And what impressed me a lot is this other kind of domestic unit in the heart of the Europe. Italy is not the heart, it's the center, but it's a little bit on the south. But I think in France is the same with this immigrant. that this domestic unit became a sort of exotic microcosm with all this globalization and people coming from one place to the other place. I have so many, I don't know if I answered, but if not, I will do another presentation. But I thank you very much for the question. It was very, very interesting, and there are many questions that I need to reflect on them. It will be a great opportunity to do that. Thank you.
I want to begin answering what Naomi asked for me, and first of all saying that it was a real pleasure to have Naomi with us, and also this year Rachel was there. Naomi was more directly related with PASA, and Rachel with another project that's where the agentes comunitários de saúde, I don't know, community agents are working. And it was really great to hear Naomi, and it's important also to say that she has written a work about what she saw there in Brazil, that I think it's very it's easy for you to read, and it's also here I'm going to show you the name. And related to what she said, there in our health center, we are always really trying to keep in mind that we have these principles and that we are trying to do care with comprehensiveness, even if I mentioned all these challenges. One of the biggest is really that we have very few human resources to everything, and we deliver care. We are also like always trying to train students and also train other professionals and try to do research. So it's our biggest challenge maybe. What she mentioned about the non-medicalization is really one of our biggest issues right now in the PASA project as well. I didn't brought it now, but we have also a very small booklet about non-medicalization. We are part of a forum together with other people from the entire country that are discussing these issues. We know that also in other countries that is already a big issue. And she was asking about doing health work, so in the practice, but also making together with public health and public policy, and I think that's a good example, because we try to communicate with other groups, make a social movement out of that, and we go, for instance, to legislatory levels to discuss these projects and to try to really make laws that protect people from this medicalization and not in the contrary, because we are facing in Brazil, and I think in other countries as well, other things that are trying to put together a lot of medicalization in schools and in lives of adolescents, and of course also other people, but we are there because of adolescents mostly, in terms of behavior and so on. And also relating what we can do, thinking of working with health in the practice, and also trying to make out of it a public health issue, and to really develop knowledge and technology and teach other people. The material that this one is used inside of the practice, but this other one, this book that I think is circulating there, this is also is accessible. I'm going to show it. It was the last, I forgot to show the last slide. That was here some publications that we have, and this is the second one here. It's a training material that we developed after a research that was coordinated by José Ricardo here about ways to achieve comprehensiveness, and then specifically in the part of adolescents we developed this book that's used to train professionals in how to try to achieve some of these questions inside of the work. So we have, of course, a lot of work inside of our practice, but we are also trying to discuss how we can do it in another part of São Paulo, in another part of Brazil, and also in connection with education, with social care, and these kind of things. And in my opinion, we can also try to adapt, of course, but try to use in other countries. Of course, we have to regard to some specificities, but I think many things like activities, ideas to make it more dynamic, role playing, and discussion of very consistent issues like, for example, comprehensiveness, vulnerability, but then in a soft way in how to work that with the professionals. So that, I think that's a good thing to discuss. Naomi was also mentioning the idea of citizenship of adolescents and why we talk about it and what we think about it. And I would say, as I was mentioning before, adolescents, they are normally healthy people. Of course, sometimes they have chronic diseases. Yeah? But if we look in epidemiological measures, that's much less than the healthy ones. Okay? And our biggest challenge would be then to try to promote with them their health. But it's not in this way of a very prescriptive medicine, because then we would always be making a very tutorial work only, but really trying to, with them, improve what they really want for themselves. And in this way, try to achieve their dreams and their happiness projects in the sense of their existential projects, okay? And then that's, I think that's the way that we understand that's our role, because then we can not only be with the one adolescent in our room, but also trying to communicate with this one as part of a group, and also going, for instance, in schools or having groups with us, and always trying to see what's important for him in his life. And to achieve what's important, then I am going to take care of my very specific goals that are to prevent some diseases and unwanted pregnancy and this kind of things. But that's important only for me. That's not important for the adolescent, you know, like he's there because of his dreams actually, and we are going to try to facilitate that. That's the idea, I think. And sometimes, as you mentioned, vulnerability from outside comes into our service, and also sometimes we need to go and see what's happening to understand it better. And for instance, in these pictures that I showed you in the school, we learned a lot with the students, for instance, from things that were happening with them. They call it themselves, you know, like the name that they choose for the main character was Devil. So that's very, and even in English, that was funny. But so that's very representative of what they were thinking and why did they call themselves devil, you know? So we had to discuss that with them, you know, and also to take that into account in our further work in the unit. So I think that we have always to be in contact with what is happening to them in their day-to-day life. I think that's more or less that, in responding to you. And then after that, all the other people that made questions were mentioning, I think more specifically, things from our green form. Here, the print is in a white paper because we couldn't find green. For us, we use green because it's more or less became the color of our program. I think it's something related to hope or to being a young person. I don't know exactly why, but we use it. And also that's in our service we have a lot of these forms to try to achieve what we planned together. So it was a work that developed this, and so that's a result of many people thinking, of course. And then this version is already the new version, okay? Then for instance, I don't know your name, I'm sorry.
Luisa.
Luisa?
Yes.
So Luisa was asking about the sexual orientation thing. This didn't exist before. So if we look here in the behind of the form, it's going to be like the fourth question. Do you flirt, make out or date? Have you ever had sexual intercourse with a girl or a boy? This last question was not there before. And also not only this part actually. And then we included that after making some tests with adolescents. So we made the evaluation that I was telling to you, and the evaluation showed us that this question was very rich, but that sometimes they just gave us answers like yes, you know, and I couldn't know if it was yes, only dating, yes, having sexual intercourse, and also if it was with a boy or with a girl, and that was important for me in the discussion. Because always we present the form before, and then after that we discuss it with the kid. They take some time answering to it. They think they are really very important when they are doing that, because we leave them by themselves doing it, and they feel, you know, that they can show us their speech So we can hear to them when they do that. And then we come and discuss. And then we try to put this question here to see it. So always when we go there and it's there, for instance, it's a boy, and he answered with a boy, we are going to thematize this question. And also, so it's always a issue of after he has written, we have to discuss. The same thing with the race. We tried before other forms of asking the race. If we look, these divisions, of course, they are not very natural, but we had to try to do some divisions. But we have health, body. Race is not only body, but we left color here because it was how people can perceive themselves. But the first question was, how do you see your color? And I told you yesterday, they said, oh, looking to my leg, or looking myself at the mirror. And then that was very, very concrete, but didn't say much. And then we choose this other way that's already very accepted in Brazil, this BGE way, but we always contextualize and always ask, and that's okay for you, someone says something in your family, are everybody from the same color or not, And also the nicknames. Because here you have the nickname that they like, and here on the almost on the end of the form, we asked again about nicknames that they didn't like, and this is also a new question, because then we can have things of bullying, these kind of things. That's the idea. And I think more or less I answered. The violence you asked also. We have a question there in this questionnaire about violence, but we also discuss it, for instance, in schools. The question is specifically, remember violence, the types of violence that exist, and then if they feel themselves exposed or not. And then that's important because we can try to do something. And in one of the schools, we did a series of focus groups with this subject, and we are developing still a booklet about violence in school and institutional violence, these kind of things. You also ask about race, but that's it. I think that's most of the questions. Here also you can see Naomi's work.
Yeah. So late in time, but we have 3 more questions, and then I ask you to be very objective because we have a session just before. So please, as well, Sophia and
Okay, just very briefly, I got to know the program, by Ricardo, but also Naomi's work, and there's one, and it's brilliant work, beautifully written, very, very moving. And the title of our seminar, draws from that idea of the visions of health and care. And Naomi was very intrigued with how this kind of attention to comprehensiveness, where did it come from? And somehow she was playing it with Albert Hirschman, so the capitalistic subject has an exit, voice, or loyalty, but what about visions? So she played a little bit like maybe vision plays a role in thinking of ways of inhabiting, political economy, medicine, etc., etc. So that was where the vision came from there. But I was very intrigued, at the end of Naomi's work, and that leads me to the question of citizenship. There's a scene in which the team goes to the school. Mm-hmm. And so what do you want? And the response is money. Mm-hmm. Right? Was that in some ways, Naomi, I think she listened to one story like a teenager responded.
Teenager.
Yeah, teenager responded.
Sorry, I didn't.
Yes, I want money. So in some ways, I think, how do you deal with this? Because you're the questionnaire, mm-hmm. you are producing knowledge, but you're also materializing your vision mm-hmm. somehow. So the questionnaire, the research seems to crystallize a certain vision, mm-hmm. and you're struggling with that vision, with what health services are becoming, mm-hmm. via public funding, family planning, primary care models, etc., etc. So there's something it's almost like materializing through knowledge a certain vision. But then this question that the citizen is a consumer, is a patient. It's a complicated thing. So how do you deal with this changed Brazil, and this youth, that maybe has a dream and materialize that in a certain kind of card, but in the end they want money. They want the gadget, they want the technology, they want a job, So I wonder if the vision of social medicine, comprehensive care, has a way of addressing this desire.
I really enjoyed the panel. And my first question is about social movements. And I was really struck when you talked about the fact of social movements being connected to the change in the law. And so I wanted to ask actually both of you, if I can, kind of to think of, like, if you could reflect a little bit about the role of social movements in both the stories that you told, and give us something in terms of what that means and what we can learn from that. And then the second question kind of connects in a way, I think, which was the notion of comprehensive care and the idea of comprehensive care as it's been articulated in relationship to adolescence and implemented in relationship to adolescence, which is to say that we talk about comprehensive care in Brazil relevant to all sorts of populations. But I wonder about the specific lessons that have been learned specifically with adolescents that might be transferable to other populations as well.
Clara, please.
Yeah, so thanks for your papers. So the first, so I had a question for each of you. For Geeta, I was actually wondering, so rather than actually thinking about like, well, the Asian woman is like the one who smiles all the time, or this is, I mean, and taking those as actually the kind of categories that, those who are seeking domestics look for, I guess I would turn the mirror around and actually ask, what is the anxiety around the securing of whiteness and a securing of European identity that this tells us about in the context of larger anxieties around immigration in Europe. And it reminds me actually of Anne Stoller's work, the anthropologist Anne Stoller, who her classic work, Race and Empire, right?
Mm-hmm.
Race, Sexuality, and Empire. And really looking at actually the domestic as actually having these multiple modalities, and that the domestic worker or the slave actually occupying this very kind of, there's all of these anxieties around that worker, because it's precisely that that subjugated other that would actually be socializing the child and actually may pervert the sexuality of the child, right? And such that then would the child be white? Like, so then so there's this kind of anxiety that pervades the domestic worker that is actually tied into, I think, and I think Stoller actually shows this very well, the actual consolidation and security, the securing of European identity, which is a white European identity. And also glosses over and eclipses the kind of violence that can go on in the domestic, with domestic workers. For example, we're not just talking about the carer and the caregiver, or the cared for elderly and the caregiver. We're talking about, we may be talking about domestic situations in which you actually have multiple family members coming in and out of the house, and there are situations of, there can be rape and the production of illegitimate children. So are those women then actually allowed to keep their children? Who can socially reproduce? So I think that there's also some questions here about how we think about the domestic, the modalities of the domestic, and the questions of like the securing of whiteness that could be at stake. And so then troubling that idea of whiteness rather than looking at the marked category would be interesting. So then the second question I had for Mariana, which I thought was really interesting, but one of the questions that I actually had for the, in terms of the questionnaire and working on questions of violence, the issue of violence, is that it's interesting to see how, in a way that there's an idea that we could actually ask somebody about violence and memories of violence, and that would be narrated, right? And so that there's a kind of presumption that violence would be told, and that it, so I guess I was just wondering how one would actually attempt to register violence in the lives of others without actually working on a model based on talking. So for example, like, that is to say that the violence would be revealed through my talk, right? Mm-hmm. So for example, like so Camilo's girlfriend, who was pregnant at the time, eight months pregnant at the time that Camilo was killed, I spent a lot of time with her actually. She's 19 years old, right? And I never dared to ask her, "Do you miss Camilo?" I mean, it just was too much, right? And it would just be so violent, actually. Well, what happened and how are you dealing with it? It was just not. So, you know, basically what we did is like, I mean, it was just interesting. I mean, we would go to McDonald's, hang out, watch TV in her room, watch cartoons with her baby, this kind of thing. And she would actually start to ask me about my relationship with Martin, my husband, right? So, how long have you been with Martin? Like, 7 years. Oh, like, so do you like going to McDonald's together? I mean, what do you guys do? Oh, like this. And so it was actually like in the kind of questions that she was giving me, probing the kind of relationship that I have with Martin, that she was actually revealing or showing, not, you know, showing the contours of her relationship with Camilo, and actually showing to me her loss, right? So I guess I'm just wondering, is there a way to think about violence that is not necessarily implicitly based on a trauma model of violence, and can that be incorporated into the practice of the clinic? Or like, what would it be to actually register that violence in the clinic and in the community in a different way? So.
Okay. Yes.
A conversa vai continuar depois, mas a gente tem que ser lento. A gente já estamos passando 5 minutos e ainda temos o break.
Yes.
Então tem que ser só um comentário final e a conversa continua. Desculpem, eu gosto de tempo. Sorry, I'm saying that I'm the guardian of time.
About colors, no? So just to begin, about colors, Lilia asked me before, I had no time. In Brazil, of course, the idea of, and the defense they made of the new law for the domestic worker is because of the relationship with slavery, and slavery is the black. In Italy is different because they are more white, and the elderly they take care, or the family of the elderly they take care. So this idea of European, it's really very complicated. In Italy, I heard an expression that impressed me a lot: extracomunitario. So extracomunitario means that person that don't belong to the European community. So the idea of Europe is very related to the countries that take part in the European community, no? But I think that this relation of domestic workers and slavery, the violence is very evident, no? The idea of violence is so. Because of that, she asked me, who is pro-law? Everyone is pro-law. But after people begin to tell, oh, I am a psychologist, I win $100, for example, and I have to pay to take care of my mother, I need 3 people with this new law. So I lose my work and go to take care of my mother, but I went to work because my mother was making me crazy, you know, because she. So it's a very complicated situation, but there is not a rhetoric to say you are against the law, because we don't want to be political incorrect, and you don't want to the idea of slavery, we want to be distant of it. No? Like Lilia has a research that she told us, in Brazil, if you ask someone if he is racist, he'll say no. You know someone is racist? No, everybody. So racism is something that no one wants to tell he is, but he knows a lot of people that are.
So, okay, João asked me about this contradiction, perhaps, between being a citizen and being a consumer that the adolescents sometimes want. And I think that happens probably with all of us. And in Brazil, I think we have this tension happening. And I put here this last picture. This was also part of what they developed in this last group about dreams. So one of the dreams was to have freedom. So liberdade is freedom. We can also already think that's bourgeois, right? I don't know, but anyway, it's an idea of being free. And sometimes when we look at this form, they have wishes only for them, and sometimes they have wishes for the community, for the the family and for the communities. And also it depends a little bit from their ages. So the youngest ones, mostly they want things like very material things, like I want to have a video game, I want to have a bicycle, and it's always, they understand it by the day. It's very concrete, they want it now, and they want something material. And then they change to want things for the future, and many times related to some professions, like for instance being a football player, a soccer player, or a dancer, these kind of things that they think that they are going to make money and also be recognized. And some others, the oldest ones, already start to want, for instance, to do university and things like that. And anyway, they always want to change a little bit their situation. And it's also related to consumer, I think. And sometimes they want a better world for everybody. That's very, very beautiful. We have all these narratives, and we can see that it happens. They mix it, But we have this work to try to discuss that with the adolescents. And then Sophia was asking about social movements and what it means, and for this program, for instance, I think they are very related. I think this project, for instance, only exists because of social movements. If we look into youth attention care in Brazil, for instance, it's very related also to social movements, as for instance, everything that we have learned from feminist movement, from gay movement, so all the things, the tools, they are learned from these movements. And then, of course, we developed new ones that I think can also be used for these movements, and sometimes we make these kind of interactions. I think it's a very important question. We have there, for instance, in our health center, as I told you, we teach students, and we have a curricular stage for the residents, specifically about social movements. I was now showing that to Simone. Now we are teaching them about social movements and how social movements bring issues to health and also can deal with issues that appear to health. So I think that's also a very important thing. And that's it. I thank you everybody for the attention.